everyone. I think I'm going to start right now, just to respect everyone's time. As you can see, we have a small group, and that's purposely done so that it can be an interactive session. I get to know you, you get to know me. I want you to speak up, to engage, and hopefully take a little bit of small tips for you in your practice. So before I start on my practice, or before I start the talk today and all the interaction and everything related to this, I would like to know my audience, and I would like them to know me as well. So I'll start with myself, and then I'll ask a few questions just to get to know all of you. So my name is Dr. Afrah Al-Kadhimi. I work at Kuwait University. I have great interest in critical care. I worked in Amiri Hospital for around maybe 12 years. A few of them were in the critical care unit. I did my master's degree in the US and actually in the UK, and then I did a PharmD residency and fellowship in the US. So this is me, very briefly, and then of course anytime you can ask me for any other information about me. And now I really want to know you. I know that there are a few faces that I already know, and I'm so happy to see you among the audience today. So I just want a raise of hands. Who is a pharmacist here? Okay. Who is a physician? Okay, wonderful. And who do I have here as other healthcare professionals? Nursing. Wonderful. Nursing? Physiotherapist? Physiotherapist? Nursing? Okay, so that's wonderful. So I think we have a nice group where we have people that are from pharmacy, people who are from the doctors, the nursing, and then I'm so glad to see physio and other types of specialties among us. And I know a few other people will come. Let me just say hi to our other speaker. Okay, no, everything is good. No, you're fine. If you want to speak, want to leave and come back, it's fine. Okay, and then you can introduce yourself. That's your time. Okay, so I want to ask another question. Who has less than 5 years experience? You're considering yourself students, right? You're pharmacists, so you can still say that you're from the pharmacy profession. So less than 5. Okay, who has more than 5 years experience here? Okay. And who works in the critical care? Okay, who does not work in critical care but sees critical care patients? Okay, fantastic. Okay, and then who handles, for example, or works in the setting of ECMO or knows about ECMO? Okay, very few. Okay, wonderful. Okay, so at least now I get an idea. Okay, how about platelets, anticoagulants? Who uses them in their daily practice or sees them? Okay. So they affect your practice, I'm sure many of you. And actually, I'm sure that all of you would raise your hand because I'm very sure within your practice, there is going to be a patient that you're going to deal with that is on any of these medications. So the advanced anticoagulation and antiplatelet management, let's say session or workshop that we're going to talk today about really has more than just our regular what are these agents and what do we use them for. It's more of an advanced level. So we hope that most of you at least have a background or understanding about this. I tried to put a few slides just to refresh everyone within the topic, just so that everyone, let's say, is with me as we talk along. And we're going to divide this, let's say, workshop into 2 sessions. I'm going to start talking about a little bit of let's say, drug reversal with these agents, how to handle bleeding, and then my colleague, Dr. Patrick, will talk a little bit more about ECMO and everything related to that. Okay? So I have nothing to disclose. And just for you to at least be with me within this journey, I'm going to talk a little bit or give a little bit of evidence practices related to reversal agents for anticoagulants and antiplatelets. We are going to analyze a few case scenarios together. I have a few cases that we can discuss together. And then we're going to understand the use of certain drug products because I feel that a lot of us, even though we don't see it a lot in our practice, we're not really well versed of which agents should we use and when should we use them. So why is this topic really important? Because as you can see, the use of antiplatelets, anticoagulants, I want to focus more on anticoagulants within this talk, is significantly increased. We are using them widely for both the prevention as well as the treatment. And obviously, they are associated with greater risk of major as well as minor bleeding events. There's increased hospitalizations, increased emergency department visits because of complication either related to these drugs or because of other circumstances. Bleeding risk is higher when these drugs are used in combination. So you see patients who are on dual antiplatelets or antiplatelet, there are higher risk of developing these types of risk. Now, why is coagulation really important? And the coagulation function is really important, especially in critical care or critical care setting. It's because we know that within coagulation and antiplatelet function, there's going to be a lot of alteration within the ICU. We have critical care patients, sepsis, septic shock patients, and we also have people that come in with a lot of comorbidities, for example, liver disease, renal disease, or renal impairments that also affect really the clotting factors, the drug mechanisms, the alteration of their metabolism could happen within this setting. And we already know that the ICU by itself, being in the ICU, there's a lot of risk factors that increases the risk of developing deep vein thrombosis, for example, DVT and PE. This is a nice, let's say, hierarchy of the bleeding risk based on procedures that are done to patients in the hospital and specifically also within the ICU setting. As you can see that there are some procedures that are associated with minimum risk or low to moderate risk or high risk. And we do them regularly to most of our patients. So you'd see a patient that's in and they need to do a colonoscopy, for example, or they need to get an access to a certain line, or, for example, they are going to undergo some sort of surgical procedure, or that could be invasive or non-invasive. And all of them are associated with some potential risk of bleeding. So if these are types of procedures that I don't think any patient within the hospital setting is going to be without. I want to really, as we ask a little bit of questions at the beginning, I also want to know where your confidence and how comfortable are you regarding a few topics that we're going to touch upon today. So I have a few questions. I would like you to tell me from 1 to 5, okay, how confident are you? So for the first question, how confident are you in managing anticoagulation? Let's say 1, raise your hand if you feel that this is how much you're confident. 1 being, I'm not really confident, I really need to know more about anticoagulation. And 5 being, I'm extremely competent, let's go to something next. So how confident are you in managing anticoagulation? Whether dosing them, prescribing them, or discontinuing them. Who says 1, 2, okay, 3, 4, 5, okay? So I feel like we have a different level of people over here. So some of them, they're like, I use them every day and I want to know what's next. And some of them, I'm going to learn a lot here and then hopefully I'll try and learn more as I go. The second question, how well do you handle coagulopathy in critical care? 1, 2, 3, 4, 5, okay. So also we have a different spectrum of people here. This third question, how confident are you in managing major bleeding events? 1, okay. I like that spirit. 2, okay. 3, okay. 4, 5, okay. So again, we have a different spectrum of people here. And then the last question, how comfortable are you recommending blood products? 1, okay, a lot of 1s here. 2, 3, 4, 5, okay. So I know that there was not a lot of raising of hands because maybe that's not part of your practice. It doesn't necessarily mean that you are going to be the person that orders it, as much as that you confident or comfortable when blood products are being prescribed or are going to be recommended in this case scenario. Am I confident to know which agent am I going to request? How many units am I going to request? Do I actually need it in this setting or not? And whether, for example, this patient has active bleeding or because they have or they're on anticoagulations or antiplatelet, and for that reason you want to also add or order blood products. Of course, there can't be a talk about coagulation without talking about the coagulation cascade, and I'm sure you've all come across them, and I'm sure that this is not an area that everyone likes, because if you don't do this in your usual practice, you tend to forget the different pathways, different, let's say, activating factors, where they fit into play. So I just want to really brief everyone, just so that I want to make sure everyone is at the same level. In terms of hemostasis, we have primary hemostasis that involves platelet plug formation, and then we have secondary hemostasis where we have the coagulation cascade that comes into play. It has, let's say, two main pathways, the intrinsic and the extrinsic, that lead up to the common pathway. And it really is a series of activating these different clotting factors just for the purpose of producing that let's say, or preventing that bleeding to creating that clot. And again, just so that I make sure that everyone is on board with us today, I just have this list of table that has the different anticoagulants and different antiplatelets that we have. Obviously, we have so much more than what we had a few years back. We have them in the form of parenteral as well as oral agents. And I'm not going to talk about every single one in details, what their mechanism. That's something, we assume that everyone has a little bit of background knowledge about this already. But what I do want to just, very briefly talk about is that they have now a lot of recommended indications and a lot of different, let's say, dosing related to it that's very well established. I'm not going to go through the details. I just want to make sure everyone is aware of all of this. This is another table about the oral anticoagulation. Again, a lot of established or well-known indications that have evolved over time with a different type of dosing related to it as well. And then here's just a few examples of the parenteral anticoagulation, again, what their indications are and what the typical dosing recommendations for the different indications are. Now, in terms of bleeding and the bleeding assessment or risk stratification, there's a lot of things that you want to look into in the setting of bleeding. For example, you want to see, well, what's the patient's risk? Does the patient have a high risk or not a high risk? It really depends on the patient's factor, what he's in for. Does he have any type of renal liver impairments that can affect any type of the clotting factors themselves, or the disease progression is either great or not really that great. So that's one of the things that you want to see. You also want to see if that patient had a recent surgery or not. What are the different comorbidities? What are the different anticoagulants that the patient is on? So that's one of the things. You also want to see the drug factors. What are the different types of drugs? Where is their half-life? How do they work? What type of effect are we suspecting within that case? When was the last dose, for example? These are things that you want to ask at the very beginning. And you also want to see if that patient is a bleeding patient. You want to see if that patient has bleeding is resolving or worsening. So if it's resolving, you usually see the vital signs, the clinical signs, just to see that. And if it worsens, then we generally see a lot of hemodynamic instability being, for example, tachycardia, hypotension, or obvious blood losses. In terms of hemoglobin, do we really rely on hemoglobin when it comes to acute bleeding? Hemoglobin drop is actually lag. So especially in the setting of an acute, massive type of bleeding loss, we don't really rely on hemoglobin that much. We look into trends as we go and as we manage patients with bleeding. Okay. And I have recognized that everyone has or works in a different setting. They use different lab values. They use different units. So I just wanted to make sure everyone is on board, because I'm going to refer to a few studies, and I know that maybe what you usually remember or what you usually know about certain reference ranges for hemoglobin could be different. So I'm going to focus more on the gram per deciliter type of reference ranges. Obviously, maybe that's not what you're comfortable and what's not what you use in your setting. Can you tell me, does anyone use something other than grams per deciliter? I think a few hospitals use gram per liter, right? Yeah, that's what they're used to. So I just want to make sure everyone is on board that I'm not going to be referring to grams per liter within my talk. It's really, I'm going to go with the, I think, the gram per deciliter reference ranges. Okay, so also we can't have a talk about bleeding without talking about the definition of what do we consider major bleeding and what do we consider minor bleeding, just so that when we use these terminologies as we go on, everyone is on board. So according to the International Society of Thrombosis and Homeostasis, major bleeding definition is really based on these 4 criteria. Either it's fatal bleeding that leads to death, so that's considered to be major, or it occurs in a critical area or organs, for example, interspinal or pericardial or intramuscular with compartment syndrome. And then you have a hemoglobin drop of 2 or more grams per deciliter within a small time frame, as well as the requirement of blood transfusion of red blood cells of more than 2 units, either of whole blood or 5 red blood cells. That really fits the criteria of major bleeding. In terms of minor bleeding, anything that does not fit the criteria of major would fit in the criteria of minor bleeding. I just want to also point out about the clinically relevant non-major bleeding events, because that's when we actually need more intervention. Even though it's considered to be minor bleeding or not major, they still require maybe significant type of clinical intervention. They could lead, for example, to hospital admission for bleeding management. They require, for example, a surgical treatment. They need modification of certain antithrombotic therapy. So that's what we mean by clinically relevant non-major bleeding events. Can you tell me a little bit from your practice what type of major or minor bleeding events that you'd see daily, almost daily?
Daily melena.
Melena, okay.
Nosebleed.
Nosebleeds. Yeah. Other things.
Maybe if you use sharp materials like shaving.
Yeah, exactly. What?
GI ulceration.
I could potentially. Yeah.
Inaphasia.
Yeah, exactly. Okay, so these are just examples that we see almost every day. And then how about the major bleeding events, since we mentioned examples?
Accidents.
Yes. Yeah.
Fall from height.
Yeah. Okay.
Operations.
And that would lead to significant bleeding events. Okay. Just briefly about the degree of anticoagulation. So now we're focusing on the patients that are on some sort of anticoagulation, and the extent or the degree of their anticoagulation really depends on the dose as well as the interval since their last dose that was given. The coagulation tests that we tend to use may be helpful in determining residual anticoagulation effect. I'll talk about a little, or in the next few slides, about clotting tests that could be effective while you're on these anticoagulants. Normal coagulation testing does not necessarily eliminate the need for aggressive intervention. So we don't necessarily only rely on numbers to actually determine what the extent of bleeding the patient is on or is. Okay, so I want to at least, have you be part of this from your experiences. What would you say that would happen to a PTT or PT when they're on these types of agents? Do you know what we have? For example, warfarin, what do you expect a patient to have? What would be increased, decreased, or let's say normal, the normal range, if a patient is on warfarin?
Increased INR.
Increased INR, okay.
And the APTT, because it's vitamin K, so it would prolong all of the.
Exactly, yeah.
Never mind, and I'm hematologist.
Oh, really? Okay, so you're testing all of us, right? Okay. So that would potentially increase. Okay, how about its effect on dialysis? Okay. It's okay, I don't assume that everyone would know the answer right now. I just want you to think about things so that maybe as you move forward, you have more curiosity to know what the effects of these anticoagulants are on these clotting tests. How about rivaroxaban and epexiban? Just grouping them to one group because I'm assuming they'd have the same effect. Because we generally don't monitor, right? But would we expect any of these to be increased, decreased, neutral? What? Potentially, especially in the early on, yeah. How about the INR? Not much. Could increase. Okay, do you think they're dialyzable? Just because I'm just thinking, the reason I have the effect on dialysis is because I'm just thinking if this patient has an overdose or has a massive bleeding event while they're on these agents, would I ever think about dialysis to remove the drug out?
Or the epexiban, I think that's what was studied with dialysis.
Okay, yeah, partially maybe dialyzable. Okay, yeah, it's not something that you'd see a lot of evidence on. Okay, how about dabigatran? Okay, potentially, yeah. How about edoxaban? We don't use that much, so I don't anticipate everyone to know that. Okay. So warfarin, it would increase. APTT probably could potentially increase, but not really usual. For rivaroxaban and epexiban, initially we could see an increase in INR and APTT or PT. Sometimes we do see it regularly, and that could tell us if the patient is really on these drugs or not, even though it's not regularly tested. In terms of dialysis, warfarin not dialyzable, rivaroxaban not dialyzable, epexiban poorly dialyzable, so we really don't think about dialysis with these agents. For dabigatran, it does potentially or could increase the APTT, also PT and INR. And then edoxaban, not so much for APTT, a little bit of increase potentially for PT and INR, and it's not dialyzable. And as you can see, there's different elimination half-life for those agents as well. Okay, how about the herbal agents? Heparin. APTT, obviously, yes. Okay, and then argatroban, bivalirudin. So we are going to still see an increase in APTT with these agents.
Can we have this information sent to us with this picture?
I could, yeah. Why not? It will be easier, so I want you to focus on what we talk about instead of, writing or taking pictures.
Yeah.
How about that?
Yeah.
Okay. Okay, and then how about factor 10A? Do you guys use it in your practice? Do you monitor for that? Is it something common? I know that a lot of hospitals now have it, and the turnover is actually faster than what we expected to be previously. No? Okay, so, sometimes we do use anti-10 ASAs just to monitor heparin, especially in certain population, for example, obesity, pregnancy, sometimes in patients with renal impairment. These special population. I do have a therapeutic range that is really because these therapeutic ranges, let's say of 0.3 to 0.7 international units per ml. It really varies from institution to institution. This is just a random from one of the sources that I have about the range for anti-10A. When it comes to rivaroxaban and epexiban, we could use the anti-10A, only that it's not really calibrated for these drugs, so that's something that you want to be aware of. For fondaparinux, we haven't talked about that again, but it also could potentially increase the anti-cancer level. I don't also have a established reference range for that, but sometimes these are things that we can tend to use within our practice, especially in certain populations. And we'll talk a little bit maybe about that later on. So that was just a little bit of a refresher for everything that we talked about, just so that everyone is on board as we talk and continue our discussion about the reversal agents and what's next. So really it's about finding that balance, because there are going to be situations where there's going to be interruption to anticoagulation, whether it's because of a bleeding event that the patient has, that you might think about, oh, let's stop or hold on to anticoagulation, or because the patient has a surgery or invasive procedure that is planned, or maybe it's just because the patient has an overdose or we're suspecting that we interrupt the anticoagulation. And the thing is, the patients that are already on these agents, they're on them for a reason. They already have high risk of thrombotic events. So when you stop them, we're increasing the risk of these thrombotic events happening. And at the same time, if we do keep them or not, having a surgery, for example, especially if it was an invasive one, that could also increase the risk of bleeding. So we're always in that constant situation where, okay, we need to find that balance between thrombotic events and bleeding events, and that could be sometimes challenging. Now, I know that a lot of the institution would have a standardized approach to manage a patient with these agents, let's say before a surgery, either it was an elective surgery, urgent surgery, what would we do in these situations? I know that there's a lot of guidelines. It's not going to be the purpose of our discussion today to talk about these things. I think maybe most of you are already within these level, or you know where to find your sources. It's just important to me to know if you are aware of your own institution's protocols. Do you, first of all, let's say the first question, do you have an institutional protocol or a departmental protocol when it comes to managing anticoagulation before, let's say, an anticipated either elective or urgent surgery?
I think.
For antiplatelets.
For antiplatelets,
Stop
can you remind me where
antiplatelet.
do you work?
I'm working in private sector.
But in which department and what's your specialty?
Anesthesia.
Anesthesia, okay. So obviously I would like to hear from you, what type of,
Yeah, for the dual antiplatelets undergoing surgery, we stop this one for 7 days and replacing by Lexan or the slow molecular whatever for this period with surgical bleeding.
how about in terms of anticoagulations? Do you have a certain protocol or guideline?
No, we don't
No.
have.
Okay.
As for
There's a reason, okay.
Usually it's designed as case by case.
Yes.
So it would be like a recommendation by the treating physician or the attending hematologist would write a plan for this specific patient, because some of the patients need to have one agent or they need to bridge with other anticoagulation in between. So it will be designed for the patient case.
Okay. But there's nothing that, say, standardized as a protocol or institution that you follow or you recommend, at least, for example, to help the
It's not
team
written.
make an
It's
addition.
not written.
Yeah, because that's what I see and I realize it's really based on, we see the patient, we assess them, and then we decide on what's the
Just
plan.
documents in the file what's the operative plan or the emergency plan for this patient.
Yes, that's what I realized. So this is why I can see that there's a lot of variability in practice. And sometimes that can really cause confusion to a lot of the people into, okay, what would be my recommendation? If this was a recommendation that was given, for example, for this plan, should I just trust it blindly? Am I part of the discussion? Do I have any say into this? Do I agree? Is there anything missing? For example, especially with our daily lives and, multiple, let's say, teams being part of that patient's care. So it's really important sometimes to at least, think about standardizing things. And then obviously guidelines are guidelines. We have to take things as case by case basis, and based on the patients and other factors, we make that decision. Okay. So when it comes to minor,
One point.
yeah,
Some of the doctors, even if they have the protocol, they want the documentation in the patient file, just the collegial issue. They need the plan written in the patient file, regardless they have the protocol or not.
Obviously, that's the case, yes, you're absolutely right. Even though we do have protocols or let's say standardization in some types of institutional, or we could use any certain type of guideline, eventually we have to write the patient's plan.
Yes.
But I'm just trying to think about, if you have a team and multiple people, for example, we have different specialties here, and everyone would feel more confident knowing that, oh, we all agree about that plan. So it would be easier, oh, yeah, obviously I agree to that plan because you thought about the standardized protocol, or this is the hospital protocol. So, for example, anesthesia, when they see a lot of these patients, at least, they just want to take things or make things standardized to help within that, within the practice setting. Yes. Okay, how about there are certain situations where we don't really think about reversal of these agents or interrupting or holding these. When would that be the case?
Emergency.
Emergency, obviously, there's some things that you still have to stop it, or you still have to recognize and think about, oh, when was the last time the patient took the dose? Should we give, something to reverse it, or maybe not? But usually reversible agents are not necessary if the patient has a minor bleed, or there's a slow bleeding loss. For example, if they don't have uncomplicated anemia without significant type of active bleeding, we don't tend, a lot of the time, that's one of the situations where I want you to feel confident. Okay, the patient, there is signs of bleeding, it's just minor. We talked about a few examples. There's something that we shouldn't be worried about that is not, for example, doesn't result in any type of hemodynamic instability. So maybe we don't even need to reverse these agents in the first place. However, if we do come across a patient with a serious, life-threatening, uncontrolled bleeding while they are still under the effect of these agents, because now we know about their half-life and when they would produce an effect, then that's when you want to consider reversing these anticoagulants. Okay. So
You said, sorry, can I ask, you said that a reduction of hemoglobin to gram per day is considered a measure of bleeding.
yes.
There is a time frame for this reduction 1 hour, or just a reduction?
Well, it is not going to be over like 3-4 days that you're seeing it, but it's a continuous reduction and it's more than 2, then within a short period of time.
Acute reduction.
Yeah. Okay. Now let's talk a little bit about the reversal agents. So for heparin and low molecular weight heparin, what do we generally use? Protamine?
Protein.
Yes. Okay. Do you know what's the dose? What are things that you want to think about when you want to recommend this dose? How would you dose it? For example, let's start with heparin.
What's indication? Indication, I think.
Reversal.
Okay. So I can hear 0.5, 1, depend on the indication.
Standard.
I just want to know, I pick up your thought, when you talk about indication, what makes it different?
Prophylactic or treatment?
You have a person that's on heparin, that's actively bleeding, and let's say they meet the indication for reversal, and you want to reverse it using protamine. What would be your recommended dose? How would you dose it?
Those for protein sulfate.
Yeah. What would you do when you come across a drug and you want to dose it?
What? You measure the weight?
Well, okay, maybe you need to know information about the patient. Okay.
When was the last time you took the drug?
When was the last time? Okay. Yeah.
The amount he had was really big.
What?
The amount of heparin that he was taking.
Okay, so exactly, so you want to know what's the dose of the patient, what dose was he on, if it was heparin, if it was sub-Q, or was it given as an infusion? Okay, when you stop the infusion, how long have you stopped it? And if the patient is still bleeding, do I really need to use protamine sulfate or not? It's a dirty drug. I would consider it at least a dirty drug. I don't like using it that much if I don't need to. It does come with a lot of risks as well. So I just have it here briefly. If it was heparin, it was given IV, then the protamine dose is going to be based on heparin given at least 2 to 3 hours for a continuous infusion. That's what we want to consider maybe giving it. If the patient is not bleeding, then we would not consider administering protamine. The dose, we usually use 1 milligram of protamine that will really neutralize 100 units of heparin. So you do it based on these dosing. I think I do have a few case series or cases that we can talk about in terms of dosing protamine. The maximum dose is 50 milligrams. And then one of the side effects does have a boxed warning. Do you know about it?
Thromboembolics.
Yes, it could potentially increase thermal risk.
So this dose would reverse 5,000 units of this maximum.
If you use the maximum dose,
maximum dose.
okay? But usually, you just look into, okay, what in the last 2 to 3 hours, what was the amount of heparin given, and based on that, you do your calculation. It does come with hypersensitivity reactions, hypotension, bradycardia, and I think I do have them here.
Is this
So,
renal impairment can modify those?
no,
It's not very-
yeah, it doesn't need renal modification. Too rapid administration can result in severe hypotension, anaphylactic type of reaction, so we tend to give it slowly. It can result into cardiovascular collapse, arrhythmias, pulmonary hypertension, so it does come with a lot of risk, so this is why we tend to not use it that much. Okay. The onset of action is usually within 5 minutes, so it's really relatively quick. Half-life is 7 minutes. And then what are you going to monitor when the patient is going, just so that you make sure that the heparin is reversed? It's an easy question. Maybe. Yes. So before I go to the dosing for low molecular weight heparin, does anyone have any question, or can you share any of your experiences with using this drug?
Clexane, low molecular weight.
Yeah, we're going to talk about Clexane in the next slide because the dosing is going to be different. But anyone wants to share their experience with using protamine?
Protamine is very rare to use.
Yes.
Yeah.
Have you ever come across using it?
Mostly in the club, but alhamdulillah, that's been
And then I just want to know, do you know where is it stored? Because if you do need it, at least you want to know where you can grab it from, right? Crash cart, do you have that here? Okay. Well, this is just, to open your curiosity, just to figure out, where can you find it? Because what happens, in my, let's say, little experiences, is that when they decide to use it, they don't know where to find it. Is it in the pharmacy? Do we have it stored in the nursing station? Is it in the crash cart? So I just want to make sure. So even when you tell me you don't have it, I'm like, Okay.
I think in
That's why
pharmacy,
we are suggesting rarely we suggest, and
When you do,
and it's not used.
yes.
I think
Maybe
it's
that's what you have.
Maybe. That's the thing. Everyone has a different crash cart. It's not standardized.
It is not the crash cart, you have to make sure, the cat lab, whenever you have an infusion, you have to make sure that it's.
Okay, so at least you're aware of the system, the policy of the institution where you're working at.
I think there's a device called Plexius. They store it there and it's.
Sometimes the Pyxis machine does have it. It really depends. This is why it's different from institution to institution, it's different from department to department. And this is just so that you're aware of wherever you're practicing, know where you keep these antidotes, let's say, for example, and if they're available or not, because sometimes we do have them, they get expired, and things, they're not really accessible that much.
actually we have stored box in the pharmacy contain all antidote for detoxification.
Which hospital do you work in?
For any hospital.
Okay, and where is that located? Like only in the pharmacy?
In the pharmacy. But
So if it's requested, it has to come from the pharmacy?
also, no, not requested.
This is not that much requested.
Not all antidote,
Okay.
some antidote.
So it's just, good to refresh yourself, especially if you change your departments, you change your location, you change your practice, where is it located, is it available or not, and where is it stored, and who has the access to ordering it, for example, so that it can be used. Do you know what type of allergies we worry about when we use protamine?
That's,
Yeah.
like 20.
If someone has a certain allergy, maybe you know, fish allergy. Oh, yeah. So usually, fish allergy is something that we are aware of. Not nausea, vomiting type of reaction, but more of a significant reaction. Okay, now in terms of dosing it for enoxaparin, I'm just going to use for low molecular weight because I know this is what we use in practice here, the enoxaparin. And really, we talked about the timing of when was the dose given. If it was, let's say, within 8 hours, if it was between 8 hours to 12 hours, or if it was greater than 12 hours. This is why the timing of these agents is really important when you're taking any type of patient's history on dosing. And then based on that, you can dose the protamine. And then obviously when you're giving it, it's going to be similar to the case for heparin as a slow infusion over 10 minutes. And the maximum dose is also the same. If it was more than 12 hours, then we probably would not need to give protamine sulfate in this case. Now let's talk about warfarin. So we all know warfarin decreases coagulation factors 2, 7, 9, and 10, as well as protein C and S. And the goal of reversal is that we are trying to either we're giving these clotting factors and also we are resynthesizing them again. So this is just for you to tell me for warfarin, what are reversal agents that you would think
Vitamin
about?
K, vitamin K for.
Vitamin K, which is the one that's really commonly
It
used.
takes time.
It takes time, exactly, that's the issue, because it's going to produce and synthesize these clotting factors. So in the event of severe, let's say, bleeding while you're using warfarin, other than vitamin K, what would you think?
4 plasma concentrate.
Okay, so I am hearing really great answers. So I'm hearing fresh frozen plasma, I'm hearing PCC, and we'll talk a little bit about that. Okay, and I think the thought process, I'm actually giving clotting factors right now until vitamin K works and kicks in. Okay, and then in terms of vitamin K, do you give it intramuscular, subcutaneous, IV, oral? Oral or IV, okay, fantastic. And then what are the thoughts of the dosing? Yes. So that's the maximum. If we're giving it IV, sometimes you want to give 5, sometimes even 2.5. It really depends on how severe the bleeding and the patient's assessment overall to decide on that. Okay. I do have a few questions. Let me see. Okay. So how does vitamin K reverse coagulopathy?
Increase synthesis of the clotting.
Yeah, we're producing these clotting factors. When would it produce its effect?
After maybe 1 week, 5 days. 5 days.
5 days. Wow.
Takes time.
If the patient needs a surgery right now, we're gonna wait 5 days?
No, this is not for urgent. This is not for urgent.
It's not for urgent, but if you're giving it, you wanna know when it's gonna give you that effect, because we said we're gonna monitor, let's say INR. It depends, oral or IV, okay, fantastic. Okay, it's okay. And then why should oral or enteral vitamin K not be used in life-threatening bleeding? Because it takes time. Okay. So vitamin K synthesizes these clotting factors, and then the onset of action is 1 to 2 hours, but the peak effect is really 6 to 12 hours, so there is going to be a delay in producing effect if we're giving it IV. And then it's going to be even delayed even more, up to 48 hours if it was given orally, and that's why we don't use it for urgent situation. Okay, then I just want to go back. So great, I loved how people knew what to give in terms of reversal of warfarin. So we talked about vitamin K, we also talked about PCC or 4-factor PCC, and I want to talk later on about the dosing. I want to make sure everyone leaves here knowing how to dose that, and then fresh frozen plasma. Anyone who wants to tell me, actually we'll talk about blood products later on as well, but just quickly, if we have fresh frozen plasma and PCC, which one would you want to give? What would you base it? Okay? I don't have the answer here, but I want everyone to say it with confidence, even though you don't see the answer here. We're not testing anyone here. Okay? But sometimes what happens is that in practice, you know, when at first, we're not competent enough, we have to look and make sure, and then it becomes our second nature, we're fully competent, and then we forget from where did we get that information and what's the evidence behind it. So this is why, in terms of having both of these agents, the American College of Chest Physicians, and I know a lot of other guidelines would recommend using PCC over fresh frozen plasma right now. Obviously, if we don't have PCC, which is what we tend to see a lot in a lot of hospitals, it's sometimes there and then sometimes we don't have it. So we would use fresh frozen plasma in that case. And that's really based on a lot of supporting evidence that we have right now about that.
And one point also to decide for the dosing, not only the minor breed or major breed, the INR per se
Exactly.
will guide us what to give. The patient has INR of 5 and then 10.
Exactly. Yes, I know I have them here listed very briefly because we about vitamin K.
Yes.
Definitely, and I have realized that every hospital does it differently, and sometimes, you know, they just say, okay, it's 7, okay, it's 10, okay, let's just give 5 IV vitamin K, let's just give 10. But there's not a really straight, standardized, let's say, approach, but definitely, yes, I've seen people think about bleeding, non-bleeding, and then what's the INR, and based on that, they have like an algorithm to follow. Definitely, that's very true, okay? Okay, direct thrombin inhibitors, let's say dabigatran, although I don't know if you see it now in practice that much. Still? Yeah, it's not that much. Okay, what would you do to reverse it? So I know I have the answers over here. Okay, so we do have an antidote for it. Idacruzumab or praxidone.
Yes, they show availability.
Exactly.
Available.
If it's available or not, how fast can we get it? Who has, you know, the access to request it? Right? The cost, yes. So let's say that it's not there, what are going to be our other option to reverse this agent? PCC as well, so you're just replacing these clotting factors. And obviously, both of these agents, because you are providing these clotting factors again, or you're stopping dabigatran from its usual action, then we're always at an increased risk of thromboembolic events with these agents. So that's really important to monitor. And again, we'll talk about the dosing for each of these agents in a different slide. Okay, so I think we answered this question. Does your institution have Praxibine for reversing dabigatran? No, we don't use it. I think that's most of your answer. Yes, but it's restricted. I don't think any of them. Yes, and it's not restricted, or I don't know. And the thing is, if you don't know, it would be great to see if it is available. And sometimes it's available, I think, at the talk center, certain areas. Sometimes it is available and it expires and it's never used because no one knows if it's available or not. Right? Usually, just for completion of it, it comes in 2 separate types of vial, each 2.5 grams, and then you give them, one after the other, not more than 15 minutes apart as a 5-gram dose. And just so that everyone is also familiar with the trial that approved the use of this agent, it's the REVERSE-AD trial of 2015, where they had several patients that had either life-threatening or uncontrolled bleeding, or they required an urgent surgery or invasive procedure, and they found that 100% had their anticoagulation reversed, and that they are certain patients, for example, 6.3% did experience thrombotic events. Okay, so I remember we talked about, if the patient has an operation or surgery and then they are on these agents, would I reverse or not? And we talked about antiplatelet. Oh, we have something where commonly we know what to do it, but really, is it necessary to reverse anti-10A inhibitors, for example, before a procedure? No. And the reason is because it has a relatively short half-life. It's not that long, so we don't even think about giving it another, we just stop it. And that's why I feel like, know and make sure that you are well versed about, okay, these are these agents, this is their half-life, let's say, this is the last dose when the patient has it, this is the action that I assume the team will make for us to move forward. And in the setting of renal dysfunction, just be aware if it's acute or chronic that the half-life that we're usually versed is going to be longer in that case. So for the anti-10A, what would be good reversal agents? Okay, so similar to Emiapran, we have the PCC as well as Andexxa or Andexanet alpha. Again, we'll talk about a little bit about the dosing for it. And then I do want to ask, because I know that a lot of institutions have not even seen it, does your institution or hospital include or have Andexanet alpha as part of their formulary? No?
I'm working at Ahmadi, we don't have it, but in Amouch, I think they
Anyone in MOH? I don't even.
It's the same.
Yeah. Sometimes because you're in a hospital, a private hospital, that would think about the cost, but
No,
even,
they don't bring it because that would be a very.
yes,
They really.
yeah. I think there has been requests, so I think it's available in certain settings, but only per request in certain areas. Yeah, just in case it is going to be available, we still need to be well empowered about using it. So the 2018 trial known as Andexxa 4 talked about the reversing of these agents in patients that either had major bleeding events or required it for an emergent surgery, and they found that it was useful in patients in reversing these agents, though thrombotic events were increased in 18.3% of the patients within 30 days. And then a lot of the time, the reason you'd see in certain trials that they look into thrombotic events that reoccurred, you really want to look into not only the time frame where they followed up patients, but also if those agents were reintroduced to those patients, because we usually reverse it for a certain period of time because, for example, of a certain surgery, because we think that there's an active bleeding event, and then we always have to put in mind that we have to reintroduce these agents again as quickly as possible to prevent these thrombotics. So it's not necessarily because we use these antidotes that we have captured thrombotic events. Okay, and then in terms of dosing of this agent, again, it's based on the last dose or the dose the patient gets, as well as the time from the last dose. So let's just say that we have high dose and low doses when we want to dose Andexanet or Andexanet alpha. If the patient is on rivaroxaban 10 milligrams or more, if they are on apixaban in a dose of greater than 5, and the duration of action is within, or let's say the duration of last dose was within the 8 hours, this is when we would target a higher dose, okay? And then usually the higher dose is like an 800 milligram bolus followed by the infusion of 8 milligrams per minute, and then you're going to give that over 120 minutes. And then if the dose is 10 or less for rivaroxaban and apixaban, 5 or less, or if it's greater than 8 hours since the last dose, then this is when you would target the lower dose. So it's really between those two doses. Okay. Prothrombin complex concentrate, or PCC, I'm going to talk about the unactive 4-factor that has 4-factor PCC, either Kcentra or Octaplex. I know certain centers maybe or they're aware of Kcentra. Some of them, I think, and I think this is what's available. We have the Octaplex here. They contain the 4 clotting factors, 2, 7, 9, and 10. It also includes protein C and S and a little bit of heparin as well. So we want to be careful in patients who are diagnosed with HIT. And then the dosing of it is going to be different, whether we are looking into an active bleed, whether the patient is on warfarin, or whether they are on a DOA. So if you can see the life-threatening hemorrhage or DOAC, the dose is really fixed or could be weight-based on certain types of studies, either 2,000 units or a 20 to 50 unit per kilogram. And then if you're reversing vitamin K antagonist or let's say warfarin, then I'm going to have here the dosing in terms of K-Centra. If you look into reference guide, there is also going to be a weight-based or fixed doses. I'm not going to go into the different studies about which one is better. Should we do it based on weight? Should we do it based on a fixed dose? Because what we tend to see is different practices and there's different evidence, and that would take an hour to talk about that. But I do want you to know that there are two ways of dosing it, and really if it was warfarin, it's based on INR, and based on the specific INR, you would dose it specifically, and there's going to be maximum doses based on the patient's weight. And then there's also the fixed regimen that could be a quick thing to give if we're not doing it based on a weight-based dosing. When it comes to Octaplex, I think there is a few differences in terms of the dosing as well, also based on weight and also based on different categories of INR. Okay. So in the case, we talked a little bit about anticoagulants, the different type of options for reversal, when we would want to reverse and when we would not want to reverse, a little bit about the certain drugs, a little bit about what type of dosing, what dose you think of. And now it comes to the last part. I'm not going to talk about that in so much detail. It's the use or the reversal of antiplatelets. So in the event of a life-threatening bleed or an emergency or potentially an overdose, is there a specific reversal agent that you're going to use for aspirin, for example, prasugrel, Degludec, Famotidine, or not? Then in these settings of an emergency surgery or a life-threatening bleed, what would you think about reversal agents? Or how would you reverse that? What would you think? Give platelets, exactly, because you're still you're giving platelets, okay?
Solve the medication.
Obviously, in all the cases, this is the first thing that we're going to do.
It would be lasting for 5% days, so they need something to overcome. So you just give the transfusion just to help with it.
Okay, yeah. So you mentioned a really good point. For all these situations that we have talked about, if there is an active bleed or something that where you want to do, the first thing is to stop that agent, at least even temporarily. The second thing, what is the source of the bleed? Because you want to also control that. And then you have other measures that you want to. And then the third thing is what we're talking about, the reversal agents. And yes, because we are thinking about platelets in this situation, then we have antiplatelets, so we're going to give platelet supplementations in this case. Anything else that you want to consider? Anything else that you know is a good practice that you want to give other than platelets? Because sometimes it's not easy to get platelets and you're requesting it.
Tranexamic acid will help.
Okay, so TXA,
And supportive measures.
Of course, yes, okay. And how about desmopressin? What are your thoughts about the use of desmopressin? Because it does enhance platelet function. Yeah. I've seen a lot where it has been used, surprisingly, but very interestingly. Do you know if you use it? Yes, but how about in the setting of reversal of antiplatelets? Okay, very interesting. So usually the dose is 0.3 microgram per kilogram, sub-Q or IV. It does enhance platelet function, so sometimes we do consider desmopressin as something that at least supports well especially if you want any type of supplements, so that could be considered. We only give 2 doses because of tachyphylaxis, and then you have to monitor for hyponatremia when you're using this agent. Yeah. Does anyone have any issue with its availability? Oh, really? Yeah. Usually this is why I spoke about it, because I know it's something that's readily available. It's used a lot, actually. Okay, just something to think in mind, because we tend to think about platelets when we're talking about antiplatelets reversal, and sometimes we have this drug that can be easily accessible and potentially also be helpful. How about in terms of DOAC-associated bleeding, patients on Apixaban and Roxaban? If it was a minor bleed, are you thinking about interrupting it or stopping it? We don't necessarily need to. We can stop it temporarily, maybe 1 or 2 doses, but we don't necessarily need to do that sometimes for minor bleeds, okay?
Depends on the indication for using. it.
Exactly. It really depends on what is the indication, is it prevention, is it treatment, why, or what doses that we're on. And then we tend to look at case-by-case basis to determine if we want to reverse it or not. And I'm not really worried about minor bleeds. I really am concerned about major bleeds that are associated with DOACs and what kind of reversible agents that we want to use. So we talked about PCC, we talked about the antidotes if they are available. We talked about potentially TXA as being one of the reversible agents. But do we rely on the labs when we're reversing it? Do we rely on the coagulation tests? Do they at least give you a guide to, because we talked about it earlier on what we would see, for example, a rise in PPT or is it NPPT, anti-10A.
Does it affect the
What?
Does it affect the
No, not necessarily. It does a little bit. Some of them they do, especially if they're earlier on, they do have a slight bump within that. That's why, but we don't necessarily repeat these tests because we're trying to see if the drug is now washed out or not, or not available or not.
Just to comment, in real life, when we have major bleed, there will become other things that happen in between. Blood transfusion in between, and then if there is massive transfusion protocol, it's a different story, and patient getting FFP,
Yes.
precipitate, and this could be monitoring for the patient. CBC, there is also to monitor the coagulation.
Of course.
So they are getting all tests together.
Yes.
In
Yes.
the scenario, and nobody would think it's like.
This is for this or this is for
Yeah.
that. Yes, it's going to be regularly done. Yeah. But the thing is, and we're going to talk about blood transfusions and all that, but the thing is, I'm not going to just rely on it to say, oh,
This is the-
now this drug is cleared. Oh, okay, we're good with that. The source, for example, we manage the source and
Then
then
maybe get into the IC. and then
Exactly.
This is a different story.
yes, exactly.
Sometimes some of the medications are enzyme inhibitors, so they might increase the effect of DOA, so which means that they might increase their effect. So in that case, if there was like a bleeding, do we stop both medications or we stop like the cause of bleeding?
If I get your question correct, the drugs that have affected the anticoagulation,
Yeah, they increase their effect.
no, you don't need to actually stop them. Not necessarily, no. If you're really thinking about the bleeding event right now, and then most probably you're going to reintroduce the anticoagulant again after you decide on the source. Because at the end of the day, they're on these drugs for a specific indication,
Yeah.
and most likely that's going to be continuous. So on the long run, eventually you're going to have those agents. But sometimes thinking about the risk factors about this patient, why did this patient end up with that significant bleed, is something you want to consider. Because sometimes, for example, they're on apixaban 5 milligrams twice a day when they actually need 2.5. Okay, twice a day. Sometimes there are certain other factors that you want to see. For example, we said these drugs would have increased effect or prolonged effect in the case of renal impairment. So there's a lot of things that you want to see within that patient before making that decision about a case on whether we want to continue those two agents. Okay.
What should we rely on in this reversal? In dual? In reversal of dual medication? What do we know?
We won't, because as we mentioned, there's going to be a lot of things playing into all of this. So when you want to do your labs, your different anticoagulation, you're doing them in general because you're seeing the whole picture. You're not relying on a certain agent. The reason that you're thinking about giving a reversal is because you know that this drug is in the body and it potentially increases the risk of bleeding. So that's when you're giving those clotting factors for the body to do its thing to stop that bleeding. So we tend to regularly do those labs, not necessarily that we're just relying on those trends to see, oh, if the drug is reversed completely or not. We don't even think about that without thinking about that.
And what about Novosilver?
I'm trying not to use Novo 7 that much in my talk. There is, yes, an element of using Novo 7 yes, in certain situations.
It's extensively.
Yes.
Usually in my institution, we rely on the platelets for us to stop the medication. Whether it was below 15, we usually stop the medication.
Okay, I think what you're talking about over there is thrombocytopenia, and if it was drug-induced, that's when we think about stuff. So that's maybe a different story or a different element. We talk about different drugs that can cause thrombocytopenia, and that's why you're stopping it at certain when you, for example, you're stopping heparin in this level or not. Yeah. Okay. So let's just talk about a little bit of cases, and then we'll take a short break. Okay. So MJ is a 72-year-old woman. This is her height and her weight with a history of atrial fibrillation, depression, hyperlipidemia, hypothyroidism. She takes dabigatran 150 milligrams twice daily, along with citalopram, atorvastatin, and levothyroxine. She presents with right-sided weakness, and CT scan confirms intracranial hemorrhage. Her last dose was 12 hours ago. And the question is, what would you recommend regarding dabigatran reversal for MJ? No reversal. Itolizumab, 5 grams once, vitamin K, or a PCC. And there's no right answer because we could have multiple answers based on everyone's practice and what their thoughts on, as long as you have a justification. So what would you think is the best recommendation here? Assuming that these agents are available. Okay, great. So I hear people saying, okay, no reversal. People who say no reversal, what's their thought process? Okay. Currently, we have extensive bleeding, yes. Intracranial hemorrhage. Last dose was 12 hours ago. Do you know the half-life? And then when would you expect the effect to last? 3 half-lives, 4 half-lives, 2 half-lives? So you still have the drug in the system, basically, what I'm trying to say. And you had extensive bleed, and the dose was 12 hours ago.
I thought we do
B?
because what seems to be used, the big difference. Last dose.
No, that was indexing alpha. That's what you were. So who says A, no reversal? It's not a wrong answer. Who says B? Who would actually have the privilege of, using this agent as you have? Okay. Who would say C? No. Or D?
Can we repeat the CT procedure?
Are you going to wait to repeat it as CT to make a decision when you have these agents?
So, anything from intervention because of the age?
There's going to be an intervention, let's assume.
Depends on the availability.
Oh, I'm saying you'd have them available. Okay. So I can see there are a lot of answers, a lot of potential answers. I'm not going to say that if you say vitamin K, I'm going to say no, wrong. Okay. But saying no reversal or adding infliximab, I personally, maybe I would say infliximab. Any other thoughts? Okay. Let's do the second case. HG is a 67-year-old man, weighs 96. B, let's say A, B. And there's not going to be a correct 100% answer for this because everyone will look into several things before they make a decision. The information is so minimum that you want to think about, okay, whether are we going into procedure or not, how sensitive, what's his hemodynamics, a lot of things are going to play, where is his labs, right?
And see, it's the decision of a neurosurgeon whether they need to reverse or just keep observation. So this is what
The thing is, these things take time. And if you are still responsible for that patient and that patient's care, and you have these agents, so you want to think about, oh, well, let me use them until I figure things out, right? We'll use the medication, okay. A 67-year-old man, 96 kilogram, on warfarin for a recent DVT after a long road trip. This afternoon, he fell while biking and sustained a femur fracture requiring emergency surgery. In the ED, his INR was 3.5, and the surgeon requested recommendation for warfarin reversal before surgery. Obviously, unfortunately, I can't tell you, ask me more questions about this patient and I'll give you. But this is the scenario and these are the options. What would be your recommendation? Vitamin K, oral, once. PCC 5,000 units once. Vitamin K IV and PCC. 2 units of plasma RBCs.
CF.
Anyone has any other recommendation? D? Why D?
Replace.
Does the patient have any bleeds right now or any information about that? There's no hemoglobin, there's no, you would need more information to make that decision, right? But the simple thought, okay, I can give vitamin K, IV, I can replace this clotting factor until I figure things out. So the best potential answer would be C.
Could be vitamin K IV alone.
Could be, yes, could be, but it's gonna take a time.
Why not?
And if the person is going for surgery, depends on when the surgery. See, the thing is, we see a lot of things. We know that the person's going for surgery now, but that now is translated maybe in 4 or 6 hours.
Why not?
And in clinical practice, we recommend additional point to insert IVC filters to prevent further contact.
Yes, definitely. Yes. And these details are very important to be written because you know that they can call you. Okay, next case. JK, 72-year-old woman, history of atrial fibrillation on apixaban 5 mg twice daily, presents to the hospital, several large bowel movements, hemoglobin on admission is critically low at 5.6 grams per deciliter. She received 2 liters of Lufkin Ranger solution, was started on Norepinephrine to maintain MAP of 60 and above, while waiting blood products. Her last dose of apixaban was taken 7 hours prior to the onset of bleeding. No reversal, activated charcoal, Indexa 400 milligrams or Indexa of 8. So is it, who says A? Who says B? Who says C? Yeah. Who says D? So just going back, 5 milligrams twice a day, and it was 7 hours. So it's less than 8 hours, okay? And the patient is on 5, not greater than 5. Let's go to the table. Just where will it fit? The one on top or the one in the back? It fits actually. But the thing is, the dose is low or it's greater than, or. So if the dose is low, even though it is within the 8 hours, you'd still give the low dose.
Isn't it supposed to be 5 milligrams per day, not per dose?
5 milligrams is the last dose that was given. It's not about
Per
per
day,
dose.
and then apixaban and rivaroxaban, the doses per day, this 5 and 10.
No, it's the last dose that was given. The last dose that was given. So in that case, C would be the right answer.
So that means we go with the dose.
See, well, it depends on the table, if you see different, because they have it differently. If it's going to be greater than 8 hours, then you're gonna go with this one. If it's gonna be a dose that's less than 5 or less, or 10 or less, then you go with the smaller dose as well. If it was a higher dose and within the 8 hours, that's when you think about taking it. Case number 4, RL, 75-year-old male, admitted to the ICU after motor vehicle accident, multiple injuries, had history of hypertension, type 2 diabetes, on insulin, atrial fibrillation, on warfarin. Upon admission, received vitamin K and 4-FPCC for anticoagulation reversal. On hospital day 3, he developed acute DVT, started on unfractionated heparin. On day 4, his heparin infusion is therapeutic, but his hemoglobin drops to 6.5, leading to hemodynamic instability. Erythropoietin hematoma was found on his CT. Which is going to be your recommendation in terms of protamine use? Administer ASAP with a dose of 20 milligram IV over 10 minutes, or 20 milligram as an IV push, or high risk due to being on NPH use, or protamine is not indicated. Heparin infusion. I don't have that information. The correct answer is C. And there's something that we didn't talk about, the use of NPH insulin. Okay. Do you know that, what are we thinking about when we talk about NPH and protamine? They would increase the anaphylactic reaction in patients who are on NPH, and that's why we don't really necessarily need it, we would not be needing it.
So what is the solution?
So in that we will not give it, because it's high risk of anaphylactic reaction with using it in these types of patients. So according to the recommendation, you shouldn't be using it. Yes, yes. And this is the case where you want to, similar to, let's say, the fish allergy, this is when you do not want to think about protein. Okay. 48-year-old male receiving enoxaparin 40 milligrams sub-Q daily for PPE prophylaxis. While trying to shave himself at 6 p.m., he cuts his neck. Medical team cannot stop bleeding. His last enoxaparin dose was administered at 8 a.m. Which one of the most appropriate dose for protein in this patient? He was on 40 milligrams. Last dose was 8 a.m. and right now 6 p.m. Do you want me to go to that slide? C. So it's a C, and I hear C, and I hear B.
No, B.
B is the correct answer. 49-year-old male diagnosed with an idiopathic DVT 3 weeks ago, takes warfarin 8 milligrams orally daily, missed his INR reading last week when he went on a short vacation. Today his INR is 10.4. He's currently bleeding. He has no risk factors for bleeding. He's not currently bleeding and has no risk factors. Which is the best initial strategy for managing his patient's high INR? So now you have a high INR, but the patient is not bleeding. What would you do? Hold warfarin, hold it, administer PCC, give vitamin K orally, give vitamin K intravenously.
E,
You have a lot of questions.
This is something that you see a lot, right? Who says A? Not giving anything, just giving this stuff in warfarin. Patient is not bleeding. Who would say B? Okay. Who would say C? Okay, a lot of C's. Who would say D? Okay. So all of you agree that since the patient is not bleeding, I'm just going to give vitamin K and I'm not going to give PCC in this case. That's fine. I think most of you agree with that. It's just, really it's based on your setting and what you're comfortable with. Should I give oral or IV? How quick do I want this to be reversed? Giving the different risk factors. So I'm not going to say C or D are wrong answers. They're both right answers. I would favor the C because in this case, oral, we can wait. No problem. That should be given by me and the patient address. Does everyone agree?
How do you know that you can't predict it?
We can't predict the future, but now the person is here and they're not bleeding and it's 10. And this is why we don't have an algorithm. If we had an algorithm, it would be easy. If you have a standard protocol, it would be easy because I would at least go with what.
The American Society of Hematology, it was each INR.
Exactly.
And what to do,
Exactly.
but not in hospital.
Yes,
That's we are using it for ourselves to build the plan.
Exactly. exactly. And what happens, everyone has studied in a different place, so everyone uses their own guidelines, whether American, Canadian, Australian, local.
We need to create
And-
a noisy
Yeah, and the thing is, like, every organization has their own recommendations, especially when it comes to this. So that's why I'm telling you, it's not a wrong answer if you give me an IV. But maybe you won't give 10 IV. Right? I think that
to anticoagulate.
Yes, 10, I think 10 IV, vitamin K IV is a lot in this case.
Then he will drop and.
Yeah, and then when we get into that cycle. True. Okay, 70-year-old male, atrial fibrillation warfarin, presents to the ER with massive GI bleed. His INR is 8.2, so now we have 8.2, massive GI bleed. What is the appropriate, most of our first-line treatment for reversal of warfarin in this case? Again, there's no right or wrong answer. Oral vitamin K, intravenous vitamin K, only PCC, or erythropoietin plasma.
B, B, B.
Okay, so I hear a lot of B's.
Why don't we give
Yeah, but we don't have labs here, we don't have anything else other than the INR, 70-year-old. B and C, okay. So I think I would also agree with B and C. Okay, both of them in this case. Okay, and then you. 58-year-old male, rivaroxaban for DVT, presents after a fall, severe bleeding from femur fracture. His last dose of rivaroxaban was 14 hours ago, and his hemoglobin is dropping. What is the most appropriate reversal agent? IV vitamin K, protamine, PCC, activated charcoal. This is supposed to be an easy one. C. What would you consider activated charcoal? I know we didn't talk about that. Yeah, within 2 to 4 hours. Not in every patient as well. Case number 9, 60-year-old male, history of atrial fibrillation on apixaban, presented to the emergency department after motor vehicle accident with massive bleeding from multiple sites. including femoral artery. His last dose of apixaban is unknown. We don't know 8 hours before the 8 hours. The most appropriate management for this patient's massive bleeding. Is it going to be andexanet alpha, PCC, the different doses of andexanet alpha, or PSA, or more than that? Of course, you can see that all these examples, we're not talking about blood products yet. So we're going to talk about that. A, here are a lot of A's. So the correct answer is A. Do I
We
know
have to
the
consider
higher?
that for wisdom. Last.
Yes, because we don't know exactly. Sure. Last case for now, 78-year-old female, history and chronic kidney disease, brought to the emergency department after presenting with massive GI bleeding. She has taken apixaban for the last year, hemoglobin is 7, she's showing sign of hypothalamic shock. Her last dose of apixaban was taken 18 hours ago. What is the most appropriate management for her bleeding? So I don't have any options, this is just a case for everyone to talk about. You know, what would you do in this case, other than, let's say,
No,
We should
yes.
consider kidney disease,
she should consider what?
chronic kidney disease. Dosing.
Okay, possibly, we don't have that information, but yeah, we don't have her weight, we don't have her renal function, yes. Okay, we never talked about dosing here. Anyways, but there it was
Only
5.5. What?
No, because
Okay, so
Last dose.
when you talk about reversal, you're not thinking about any type of, let's say, PCC and
I think we have to step line with the patient first.
okay,
It's a massive bleeding.
Okay.
What we said.
okay,
Then
okay, so during all of that, do you want to consider any agents? If you do have index that's next to you, would you want to give it or not? Do you want to give PCC or not? Yeah, I think if we have, if they're available, we're probably going to use these agents, right? How about the half-life of apixaban, when we say taking 18 hours, isn't that a long time? Because we said, because I know that the patient has a massive bleed, but when I say 18 hours ago, can I not say that this drug has a short half-life and we're not really worried about the drug right now?
Kidney disease, where this will.
prolong
Oh, yes, exactly. Yes. Yes, yes, if you say the half-life is 12 hours for this agent, then we're thinking about maybe fewer days. But yes. So I think we probably give PCC and. Yes.
If the patient is not renally impaired, we will not consider any reversal.
Why not? Why not?
And the drug will not be without.
That's the question is, that's why I asked you, do you think that there's still an effect of the drug or not after 18 hours, knowing the patient's case scenario and not knowing the dose? Knowing that the half-life of the drug, let's say, is 12 hours, and now it's 18 hours past the last dose, would I still think, even though the patient, let's say, doesn't have any type of renal impairment, even though he now needs a shot, but let's say they don't, would you still think that the drug is active enough that I want to give a reversal agent? Yes. But sometimes major bleed is just like, let's manage major bleed. Let's give blood products. Let's see the source. Doesn't have to necessarily include a reversal agent. But you think about reversal agent because the patient was on this drug and the last dose was 18 hours, and the information that I have is that I don't know what was the last dose. Sometimes we think about it in this situation, did the patient overdose? Did the patient take more than what they required? A lot of things come into play. So I think we can have a 10-minute break, and then we can get back to blood products. So 10 minutes, please, and we can be back. Because I'm head, you're inside. You're inside.